right, welcome back to another episode of Sandwich Fire Department Today. I'm your host, Larry Machado. With me today, my co-host here is Sean Gilrein. Sean Gilrein is our Emergency Medical Services Officer. That's EMS Officer. Sean, how you doing today?
Good.
Very good. So we're going to concentrate this segment on Emergency Medical Services, or EMS. As the EMS officer, what's your background, first of all? You started in the field of fire and EMS how long ago?
Yeah, so I've been in EMS, starting out as an EMT basic for 10 years. I became a paramedic about 8 years ago, starting with Yarmouth Fire for 5 years. I came over to Sandwich Fire, going on my 3rd year now. So all in all, been in the field for 10 years, been a firefighter going on 8 years.
Okay, excellent, excellent. So we're going to talk a little bit, because there's a lot of confusion. Most people in small towns such as Sandwich don't realize that the fire department handles both fire suppression, fire investigations, as well as your emergency medical services. So your EMS, your ambulance. If you call an ambulance, a firefighter showing up. We basically do dual roles here in town. There's 3 different levels of EMTs. We mostly concentrate on the basic and the paramedic. Can you expand on that a little bit?
Yeah, so like you pointed out, the fire service, we're kind of cross-trained, so we have different roles. And the fire department, 65% of the calls is EMS calls. So that's rough number.
Okay.
4,200 calls last year, 2,900 of them were EMS calls. So responding to that scene, we're all trained as EMTs. That's our basic level of training. That training for an EMT basic is roughly around 6 months. To go on to that, we have EMT paramedics. Our department has 34 EMT paramedics. That training is roughly around a year of classroom, another 6 months of hospital hours, followed by a few months of ride time hours in the ambulance.
Right. So as an EMT, basic EMT, if you show up to my house as a basic EMT, what can you do for me to help me out medically?
Yeah, so the training for a basic EMT, we're going to be there to blood pressure, listen to your lung sounds, any type of splinting, backboard. We do have, EMT basics have extensive medical training as far as that is concerned, and you will be brought to the hospital at a BLS level. Oxygenation. There are a few medications that you can give, albuterol, EpiPens.
So Sean, as a basic EMT, showing up at my house, what can you do for me as a basic EMT?
So for the Sandwich Fire Department, a basic EMT, sometimes they will be the first on scene, and there'll be a medic requested to that scene. So initially they might be starting your blood pressure, checking your blood pressure, gathering information as far as what type of medical history do you have, what types of medications you're on. Okay. They'll be listening to lung sounds. There are some medications that they can give, but they cannot give the amount of medications that a paramedic can give.
Okay. So BLS is basic life support. So as we use these acronyms very often in the field of emergency medical services and hospitals and fire departments and police departments, we'll try to make sure we explain these to the citizens, because not everybody understands what it means. So BLS is basic life support. That's what our basic EMTs can do, as Sean just pointed out. So as you move on to ALS, advanced life support, that's a little more intriguing and a little more complicated. That's reserved for our paramedics a little bit, because it shows the extra training they have to go through. What is the ALS advantage?
So the ALS advantage, I would say, we have the ability to do different things in the house during transport. We brought the LifePak 15, which is our cardiac monitor. So our paramedics have the ability to, hook you up to the LifePak monitor, put you on the cardiac monitor, and actually interpret your rhythm. We can do a 12-lead EKG and see if you're having a heart attack at that time.
Okay.
The positive of being in Sandwich, we have 2 cath lab available hospitals, very close to us, that being Cape Cod Hospital and BI Plymouth.
Okay.
So in that circumstance, there is a huge advantage for ALS.
So essentially, as paramedics with the monitor that we use here, the LifePak, we have the ability to do pretty much what the docs and the nurses are doing in the emergency room, looking at your heart from inside, multiple different views, and being able to interpret that through our training and establish whether or not you're actually having a heart attack that we need to get you to a appropriate facility.
Yeah, absolutely. Definitely to an extent. We're all trained as paramedics, advanced cardiac life support, which gives us that training, that in-depth training on different rhythm recognition and different pathways to go down.
Okay. So looking at hospitals, we talked about hospitals, and you did mention Cape Cod Hospital and BI Plymouth having cath labs active. We transport to 4 primary hospitals. We can transport to Cape Cod Hospital, Falmouth Hospital, Toby Hospital, and BI Plymouth. A lot of times we like to accommodate the patient and their family.
Yes.
Whether it's from where they're from, the area they might be visiting, might be coming down from the Cape, from off Cape, and we might want to try to get back to a closer hospital to their house. What is the final determination as to where we transport? Like if I've had patients say, no, I really want to go to Cape Cod Hospital, and we're up on Snake Pond Road just before we enter the gate, and there's something going on. How do I explain to them?
So it's what's most appropriate for that patient.
Okay.
So if that patient's completely stable and there's nothing acute going on with that patient on Snake Pond Road and they want to go to Cape Cod Hospital, we'll transport them to Cape Cod Hospital.
Okay.
But as you brought up, if something was going on or you thought something was going on and that patient's potentially unstable, the most appropriate hospital for that patient would be Falmouth Hospital, which would be closer.
Okay.
So that's how we determine those different things.
All right. So as much as we try to accommodate every patient and their family requests, sometimes we just can't do it, and that's based on our protocols, our statewide protocols, what we can interpret in the field that is actually going on with the patient. I've noticed lately we've had an increase in traumas. Now, trauma is something that it's not a medical emergency. It would be a car accident, it would be a fall, it'd be a burn. I've noticed an increase transports to South Shore Hospital. South Shore is a level 2 trauma.
Yeah, South Shore is a level 2 trauma, so they're a point of entry for a trauma center. So what happens in, an example would be there's a car accident,
okay.
Say on Quaker Meeting House, and the first arriving crew, identifies very fast that this patient needs a level of care that can only be seen at a trauma center. Okay. So then that patient would need to go to South Shore Hospital, or we would activate MedFlight and meet MedFlight at one of our landing zones.
Okay, so landing zones. We have several landing zones in town.
We do. Predetermined
landing zones. What if we decide we're gonna take this patient to South Shore Hospital because MedFlight's not flying?
Yep.
That's because that's the closest level 2 trauma center.
Yes.
What about, why can't I take that patient to Cape Cod or Falmouth? They're right here, they're closer. We just talked about going to the closest appropriate facility. For this trauma, why can't I go to Falmouth or CCH? My family's from here.
Yeah, so the issue with that is because they do not have the services that South Shore Hospital would have as far as being a trauma center.
Okay, so essentially, we bring a trauma to South Shore. We walk through the door. We have surgeons ready to go in the room meeting us. We have docs. We have a full respiratory crew. We have everything we possibly need so that if the patient's trauma issue can't be controlled right here, the surgeon's there and they can get them up to the operating room and take care of everything appropriately, or can they actually do that stuff there?
They would take them to the OR.
Okay. So a lot of that it's right there. You've got, instead of at a local hospital where you'd have to bring the emergency room staff to the patient, you evaluate the patient, determine, okay, yeah, they need to go to surgery. Now you got to get a surgeon to come down. Now he's got to evaluate them. We're at these trauma level facilities, they're all at once. They're all meeting at the same time. They're evaluating the patient. They're getting the story from the crew that picked them up. They find out what's happening and they make that determination immediately.
Yeah, the big thing about these hospitals, these trauma centers, is Cape Cod Hospital, Falmouth Hospital, BI Plymouth, and Toby, they're all great hospitals. Mm-hmm. The advantage to a trauma center is you have the ability to get that specialty in that room, sometimes within minutes of that patient entering the room. And that's what's big, and that's what's important, because obviously in a trauma, time is important.
Right. Okay, excellent, good. Some of the advances we've made in EMS, I know since I started my career, going way back when, we used to have the metal stretchers, aluminum stretcher, the silver stretchers. 2 people had to pick it up, had to put it down. in Sandwich, we were one of the first departments to go to the power loads and these power stretchers, and people were looking at it as we're spending money unwisely, and we don't need to have that automatic stuff. Why can't they just pick the stretcher up? Since we've put the automatic stretchers in, the automatic electric lift and the load stretchers, there's been a decrease in injuries.
It's injury prevention, and a lot of departments have looked at it like that. Going back when you started, how heavy were those stretchers?
They were pretty heavy.
So you're not only lifting the stretcher, but you're also lifting the patient that's on the stretcher.
Right.
So with this power load system, it's doing all the work for you.
Okay. So I actually have some. I was an opponent to it at first. I didn't want to be bothered with this. I felt that 30 pounds on the stretcher with the batteries and all of this, it wasn't worth it. And now when we were limited for manpower, we get a good 300-pound person on there, and it's me and my partner, and I'm second guessing it now. I like them.
Yeah.
I like them a lot better now. I just push the button, it goes up, down, loads by itself, saves my back, and saves me from not having to take time off from injury, which means that there's less overtime to cover those shifts. I don't have to worry about medical costs now on my own back, as well as taxing the department for treatments. So I think I was skeptical at first, but I think I'm a believer now, so I enjoy that. CPR is another big question we get about. We teach CPR classes.
We do.
If somebody wants to take a CPR class, how do they go about registering for a CPR class or enrolling with our department?
So for us, they can either call myself or Captain McMahon.
Okay.
Just call the station, ask for one of us, and we'll go to our voicemails, or they can email us. I think you have my email right there.
Yes.
So it's sgilrein, SGILREIN, @townofsandwich.net, and we can set up an appointment.
Okay. So yourself or Cap McMahon, you can call 508-888-0525, press extension 4. That'll get you through to our administrative assistant. You can leave a message with her, Lisa, and she'll get it to either Captain McMahon or Sean, and we'll get you set up with a CPR class. So along the lines of CPR, one of the things that we've learned in the last several years is compressions is the number one. That's the big thing. Get on the chest and stop pumping the chest for somebody who's in cardiac arrest. Driving down the road in the back of the ambulance, how easy is that?
Oh, it was horrible. Like you said, early CPR and defibrillation is what saves these people who go into cardiac arrest.
Okay.
So it's when that person goes down and their pulse stops and they're not breathing. As soon as you can do CPR on that person, that increases their survivability.
Okay.
So that's what's really important, is that nonstop CPR. So driving down the road, like you said, that creates interruptions, because even the best person can't do it as well as you should be doing it. And so I think you're bringing up the Lucas.
Yes, I am.
Yeah.
I'm heading that direction, and for a good reason. Our police officers are trained in CPR as well. They're trained to the first responder level, and I think there might be a couple of actually our EMTs.
Yes,
and they're there. They're there right on the spot, real quick. They're great responders for us, and they can start the CPR. The average person who starts CPR compressions on somebody, in the best of their shape, gets winded less than 2 minutes in.
Mm-hmm.
Okay, so to try to rely on good, accurate compressions is difficult. So another one of our advances we brought up was the Lucas machine, and it looks like an awful contraption, but you place a backboard behind the patient, you put this machine on top of them, you lock it in, you take the plunger and you stick it right on the chest, secure it, you press the button, and it does the compressions perfectly. Now we don't have to worry about somebody standing up in the back of the ambulance. So we're driving down the road trying to get around people who are not pulling over, who are only pulling over partway, or slamming on their brakes in front of you. And now we don't have paramedics or EMTs falling all over the place.
Yeah, absolutely. This mechanical CPR is better than any compressions that anyone can really do. And it's sustained too. So you might have great CPR for 30 seconds, but then like you said, you get tired. And you can actually see this on the monitor, because they're also on the monitor when we're doing CPR, and you can actually see the compressions being done.
So every time somebody's doing compressions on a person who's in cardiac arrest, they might not have a heart rate that we're picking up on the monitor, but we're going to actually see the compressions.
Yes.
In the form of a wave, or a cardiac wave. Good, very good. The next thing we were going to talk about was strokes. Strokes, that's another big one that keeps coming up. A lot of people keep asking about strokes. What can I do? They get confused between a heart attack and a stroke, and what's the difference? So the acronym that we like to use, the algorithm or acronym that we like to use is based out of the American Heart Association, and it's FAST, F-A-S-T. So the first thing you want to do with the F is look for facial droop, right? One side versus the other should be drooping. That's a good indication the patient might be having a stroke. A, arm drift. If you put both arms up and one keeps falling down, that's a good sign they're having a stroke. S is speech, slurred speech, and T would be time, okay? T is when did the event start? When was the last time you knew the person to be well? How long they've been going on? And get to 911, call 911 right away. Those are the 4 big things you want to look for. The key with a stroke is it's going to be all usually on the same side, is that right?
Yeah, so what you might see facial droop, you might, with the arm drift, you know, I know myself and I'm sure you too have noticed a lot of people call because, you know, a family member's having difficulty eating. They can't pick up a spoon or a fork, and that's why they call 911. That's when they notice the arm weakness or the hand weakness, and then they start to notice other things. So it might not be all of these together. You might only notice one thing. You might only notice the arm weakness, and then a few minutes later, you notice the speech. It's a little slurred. And then you see a little bit of facial droop. So all these are important, but it's important to call once you see any of these signs.
Okay. So facial droop, arm driftness or weakness, slurred speech, and time. When did this all start? Absolutely call 911 right away. And it's important, I can't stress enough, to note the time that they were last known to be well. That means the last time you knew this person to be okay, speaking fine without a problem.
Yeah, it's always important. If you have any questions of any of this, just call 911. This is what we go to. This is what we're here for.
So I'm glad you brought that up. If a citizen calls 911 and we go out to their house, how much do we charge them? We don't charge them. If we just go out there to evaluate somebody and we don't transport them. Is that correct?
Yeah, no, yeah, absolutely, we don't.
So we don't charge them. The bottom line is, don't be afraid to call. That's what we're here for. Okay, you're not going to get a bill for us to come out and check out somebody who you might think they might be having a stroke or might be having a heart attack or just isn't feeling right. A lot of times people present with all of these signs and symptoms differently. Some of them feel all of them, some of them show some of them, and some of them just don't feel right. And that's the one I think scares me the most, is when they just don't feel right, because it could be anything. It's kind of misleading, and you're really going to do some detective work.
Yeah, it comes down to, you know your body best, and your family knows you best. Mm-hmm. So if you think something's going on with yourself, or your family thinks something's wrong with you, it's always safer and better to call 911.
Right. So don't be afraid. Don't hesitate. Give us a call. We'll come out. We'll send an ambulance out. We'll send out a crew. Take a look at you. Make sure all your family member, make sure everything's well. We'll give you some vital signs, take your blood pressure, put you on the monitor, and we'll give you a good explanation as to what we think is going on. And if we can't figure it out, then we definitely will take you to the hospital. We have no problems with that at all. That's about all I have. Do you have anything else you want to add?
I don't.
All right, good. Well, thanks for tuning in. Once again, if you need to contact Sean, you can contact him at sgilrein@townofsandwich.net, and that's SGILREIN@townofsandwich.net. You can contact me at lmachado@townofsandwich.net. That's LMACHADO@townofsandwich.net. And we're just about out of here. Well, let's head to the big city. All right? Thanks for coming in, Sean.
Thanks.